building up what we call spasticity surface. As an introduction, spasticity is a common consequence of the neurological disorders, various neurological disorders such as stroke and multiple sclerosis, and globally all causes of the upper motor neuron lesions or the pyramidal tract lesions. Its impact ranges from mild impact up to complete disability and the limitation of the movement of the person. For the prevalence, actually in the first 4 weeks after stroke, it represents 4 or affects 4 to 27% of the operations, and in the next 3 months it reaches about 27%, and after the first 3 months the percentage increases up to 43%. Spasticity actually is a velocity-dependent increase in the atomic structure flex, what we call the muscle tool. It's a velocity-dependent increase in the muscle tool. The velocity, by velocity, we mean the velocity of the passive stretch, okay, which is flexion or extension. Once the spasticity develops, it will lead to a vicious circle of the following events. Start, it prevents the muscle lengthening. Furthermore, this will lead to unproposed contraction due to these spasms. This will lead to abnormal limb posture. With a long-term condition, you will develop soft tissue shortening. This will lead to biochemical changes in these affected muscles and further prevention of the lengthening of the muscle and continuing this vicious circle. Actually, the muscle tool is a type of the stretch reflex. So, the spasticity development is something abnormal in this stretch reflex. The stretching of the muscle physiologically activates and generates this stretch reflex. But in cases of brain lesion and the spinal cord lesion, we lost the supraspinal inhibition of this stretch reflex, so it will increase. This will result in a stretch reflex that comes earlier and stronger than expected or than it should. This is what we call the upper motor neuron syndrome, which is the result of most of the brain and spinal cord lesions. It includes positive symptoms and negative symptoms. The negative symptoms actually will be masked by the positive symptoms. It will not distract our attention in the first assisting of the patient, which will be in the form of loss of finger skills and loss of the selective motor control and globally motor weakness. But the positive symptoms will be more obvious and attract our attention, which are spasticity, spastic dystonias, and spastic core contractions. Also, the 3 elements can occur post-stroke, and it's very important to differentiate between them because the spastic dystonias and the spastic core contractions will be misleading and will be misdiagnosed and can be misdiagnosed as spasticity, and this will make the treatment completely different. What's the functional impact of the post-stroke spasticity? And I want you to concentrate on that more functional, because the osmotic impact and the psychological impact comes in the next step. But actually, the function is our main concern because our aim is to rehabilitate the patient after stroke, to reach a proper function. Spasticity leads to friction of the joint movement, globally limits the mobility of the patient and abnormal postures. Actually, it affects the hygiene of the patient, especially due to closure of hand, fist, and abduction of thighs. This is a very big problem. Actually, the spastic muscles will experience trigger painful noise, which may be affecting the patient, and actually it interferes with sexual relations. How to evaluate this spasticity? It's a hierarchy we must follow step by step. First of all, we should differentiate the spasticity from other causes of increased pain, like rigidity, which develops from the extravertebral tract infection, and actually the rigid content, which is increasing the muscle tone proportional to the force. The curve is proportional to the force, not to the velocity of the stretch like the spasticity. after differentiation and exclusion of other causes of increased mood, identify the potential triggers. What are the factors that increase the spasticity, like stress, like infection, like whatever? These elements should be eliminated first before treatment. Number 3, or the third step, is to measure the spasticity. We have scales to measure the spasticity. What is the grade of the spasticity? Because this will determine what type of treatment we can use. After measurement of the spasticity, we should assess the function, because the grade of the spasticity is a matter of examination of the patient, and the impact on the function is what concerns the patient himself. Okay? Measuring the spasticity by the scales, we have some few scales used worldwide, but the Ashut scale is the most widespread over the world. We have also another one which is called the scale, but it's mainly French scale and usually used in France. Okay, but the Ashut is modified Ashut specifically is more worldwide spread. It includes 5 or 6 grades, starting from 0, this is the normal patient, or this is the normal muscle tone. In grade 1 positive, and blah blah blah, reaching the maximum degree of spasticity. The first degree is a slight increase in the muscle tone. After that, slight increase in the muscle tone throughout the range. Number 3, this is the moderate increase in the muscle tone, but the passive movement is still easily related to the doctor, the examiner. And then the increase in the muscle tone reaches to the degree that the passive movement becomes difficult. Finally, marked increase in the muscle tone that the affected limb becomes rigid and feeble. This is the scale I not thoroughly because it's not right. So, then after the assessment, it's time to treat. We have physical and pharmacological and surgical interventions to control or to service the process of spasticity. Our aim is to reduce the impact of spasticity. Number 2, to improve the function and hygiene and nursing. Number 3, the caregivers. I would like to tell you that the first item is what is the concern of the community. We want to decrease the impact of spasticity on our country. Number 2 is the patient's concern, his function and his hygiene. Number 3 is the concern of the caregivers. These are the 3 elements that are affected by the stroke or the spasticity factor. Management of spasticity to be effective, first of all, as I told you, I must identify and eliminate the aggravating factors like the infection, like the stress, and second step, to use the non-pharmacological interventions, which include the passive stretching and the strengthening exercises and standing physical modalities. These are all types of the rehabilitation modalities used by the rehabilitation physicians. And finally, the medicines, which are the drugs. What's the approach time to treat or to interfere with spasticity? These are the steps we use to reach the treatment we told before. Identify or eliminate the other causes of increased muscle tone, then the triggers, eliminate them or treat them, then measure the spasticity and assess the impact of the treatment. Never to treat before being sure of what is the grade and what is the functional goal of the patient. I mean, I must detect that the patient has the following grade and it is treatable, because in the high grades it's difficult to treat. Number 2, we must ask the patient what's your goal. If his goal is matching with what the treatment can introduce, we can go. But if his goal is different than what can we do, so we must revise his knowledge about this. Okay? This is the algorithm. When we face a patient with spasticity at our clinic, how we will manage. Number 1, the patient is spastic or not. I mean, the post-stroke impact causing our normal. If no, Treatment is also required, but it's required to maintain this state and prevent further complication. And give them this treatment and then wait and monitor. But from the start, that spasticity is present and causing harm, we should identify our goals and our patient goals. We should match each other. Then treat the modificative factors first, okay? And be sure that the patient awareness by the spasticity and its impact and the goals of correction is full. If not, postpone your treatment and start what we call the self-assessment program for the patient. Self-awareness program for the patient. After the patient becomes fully aware by his problem and the goals and what we can serve, so move to the first step, which is the physiotherapy and the orthopedic ways to treat the spasticity. And if it fails, so it's the point or it's the time to consider the oral medication, botulinum toxin, and the injection of intrathecal baclofen and surgery. Okay? About the non-pharmacological interventions, the non-pharmacological means the rehabilitation programs. It includes the passive movement programs and exercise, posturing, and the posturing is very beneficial, has a very beneficial effect on spasticity, and physical modalities. All of them are more closely related to the rehabilitation decisions, and they must work side by side with us. About the pharmacological therapy, which are the drugs, we have a golden rule, which is start low and go slow. That's the meaning. Start low, I mean you should titrate the dose very accurately, because all the drugs used to treat the spasticity, especially the oral medications, have intolerable side effects like sedation and chronic fatigue syndromes and others. So we must start low. And about going slow, we mean that you should try the drug for a sufficient period, long period, and reach the maximum permitted dose, and you can combine two drugs if needed before you can claim that this patient will not be benefited from the pharmacological treatments for spasticity. These are the commonly used oral treatments for spasticity. They are all causing muscle relaxation effect on our different mechanisms: the baclofen, benzodiazepines, the gabapentins and pregabalins, tizanidine and dantrolene, especially dantrolene. About surgical intervention. Surgical intervention usually comes late, or I mean it's the last step. Otherwise, the rehabilitation programs and the pharmacological treatments can go side by side. We have different types of surgery that can serve patients with spasticity, and actually the highest casualty score, 4 or more, 3 or more, like myelotomy and cordotomy, stereoisotomy gives very good benefits. Also, the orthopedic procedures like lengthening of tendons, tendon release, transfer of tendons. The aim of these surgeries is to elongate the shortened muscles, as I told you before, that our pathophysiology including short of the actual size of the muscle. Here we reach the point of our discussion today, that among these pharmacological treatments for spasticity, recently, about the recent 10 to 15 years, we found a very beneficial effect on what we call the Clostridium botulinum toxin. Okay, and so it becomes a matter of discussion and a matter of science by as an entity alone. Okay, Clostridium botulinum is a bacteria, type of bacteria, which is gram-positive anaerobic bacteria, rod shaped. It produces a group of toxins named A, B, C1, D, E, F, G, I'm talking about the toxopinate because it's available in my country with no antibiotics. The molecular structure of this toxin, as you see, is composed of two components. The first component is the neurotoxin, which is the active component, or the active part, which is the small part, and its size is 150 kilodalton, and the other side is just a carrier for the neurotoxin, which is the non-toxic protein, and it's called hemagglutinin and non-toxic non-hemagglutinin. Its function is just to carry the active part. How it works? When this toxin is injected in the muscle, it diffuses in the muscle fibers and reaches the neuromuscular junction. It passes by this first step is binding. Toxin binds to the presynaptic terminal. Okay. The next step is the internalization. It becomes internalized inside the presynaptic terminal. Then the light chain, which is the active part, it translocates inside the presynaptic terminal and reaches the chemical transmitter vesicles, where it binds to the SNR protein complex. This binding to the SNR protein complex leads to the next step, which is the cleavage. It enables the toxin to exactly the light chain to cleave the membrane protein, which is called the SNAP25. The cleavage of the SNAP25 results in failure of the exocytosis of the chemical transmitters from its vesicles in the presynaptic terminal. Here, I must concentrate on the schedule of chemical transmitters. Mainly, we need the acetylcholine because it's important for the main chemical transmitters for the motor activity. But don't forget that actually there are other chemical transmitters that are incriminated in the pain transmission. So, this toxin has a sensory motor inhibition. This is what I want to tell you. More video, about 3 minutes, discussing the mechanism of action. Sorry, the sound. I think the sound is not really audible. components, boxes. Finds the receptors, three-synaptic terminal, then internalize inside the three-synaptic terminal, cleavage of this finding of the active part moves to the SNAP25 region. So the presynaptic vesicles will not found the SNAP25 and will not release its chemical first. These are the licensed or the FDA approved indications to use clots, which are blepharospasm, hemifacial spasms, cervical dystonia, we call it systolic clots, focal spasticity, and hyperhidrosis. Exactly the persistent severe primary hyperhidrosis of the axilla after failure of other topical medications, bladder dysfunctions, but especially the idiopathic overactive bladder and the urinary incontinence due to neurogenic diffuser overactivity following the brain injuries and the spinal cord injuries and multiple sclerosis. Finally, the chronic migraine, we will discuss later. So the plus have will reduce targeted reduction of hypertonicity and transient reversible effect. What's the evidence for this efficacy? This is a randomized double-blind placebo controlled study of hospital spasticity patients. Actually, the number of the patients were 126. They were studied for 12 weeks and compared to the placebo. The group of them got tox, the 126 patients received tox, and compared to others that got placebo. And the disability scale, and we will discuss it later, was done, and we found improvement. The one in blue is the tox, and the one in black is the placebo, and we found marked improvement in the patient's disability score after injection. Actually, we studied some analysis of data, were pulled from a study. Double-blind placebo-controlled, double-blind placebo-controlled trials done on 644 patients, and it was done to prove is there is a relationship between the dose and the efficacy of the dose, and found to be yes. As we increase the dose, we will get more benefit in the form of increasing the dose, as with the scale get down. Don't forget that zero the actual scale is the good step. So when it gets down, so we are improving. Okay. These are the common side effects that can be faced with the toxin type A, which is the tox, compared to the placebo. They are pain, arm pain, headache, dizziness, muscular weakness. Actually, it's vocal muscular weakness in the muscle, incoordination, infection. Ecchymosis at the site of infection, and hypothesia, at the site of injection, and hypothesia at the site of injection. That is openly faced or clinical practice. This is the biofilm. This is the biofilm of box worldwide, the same color and the same design. Each one contains 100 international units of material toxin. It's vacuum sealed to guarantee the sterility. How do we construct the vial before use? Number one, the preparation. You should draw an appropriate amount of the dilution of the dilutant in a syringe. Okay, usually we use normal saline, and the syringe to be used prefer to have the following criteria: specific caliber and specific length. Okay, the international international standard diameter is the 21 gauge, and the international standardized length of the ceiling is 6.4 centimeters. Okay. Number 2, cleaning and needle insertion. We should clean the site of injection, and usually we can use alcohol, but be sure that after using your alcohol, you must remove it from the skin of the bottom and don't inject immediately after putting the alcohol, because if some alcohol diffuses through the whole injection, it will destroy the toxin and it will not be good. Okay. Then after putting the diluted, which is saline, gently mix, not like that by shaking muscle, but just turning the bottle, using some by turning the vial like that in a little manner in a gentle way. Okay. Then go away back the reconstituted bottles in another sealing. Okay. Okay. One concern during the reconstruction, this is I will withdraw the saline, and then when I introduce the saline inside the vial, I should go in an angle 45 degrees. Okay, not perpendicular line, because don't forget that this vial is vacuum sealed and the toxin is in the bottom and it's very fragile component. If you introduce it perpendicularly, the fluid will rush and hit the toxin and it will be damaged. So if we introduce the sealing 45 degrees, the fluid will rush to the side of the vial and it will go slowly to the toxin. Okay, the second point is the shaking. Don't shake. Okay, mix lightly, gently. Then withdraw it back in a sealing. Usually, you draw it back in an insulin sealing. This one. Okay, because with the insulin sealing is graded 100 points, and this will make the calculation of the dose will be easy. Okay. What's the amount of the saline used to dilute it? You can use different amounts of saline. Actually, the standardized and real-world spread is diluting the vial in 2 milligrams of saline. So, the vial has contained 100 units, international units of toxin. So, each milliliter will contain 5 units. Again, vial contains 100 units. If we put 2 milligrams of saline, okay, so the 100 units are diluted in 2 milligrams. Okay, so each milliliter contain 50 units. Each milliliter from the diluted saline contain 50 units. This milliliter will be withdrawn in a full sealing like that. So this sealing now contains how much units? 50 units. Each sealing of this can occupy 1 milli of saline. We introduced 2 millis, so it will be re-withdrawn again in 2 sealings like this. Each sealing contains 1 milli. So each sealing contains 50 units of the total 100 units. So when this one contains 50 units, and it is divided into 10 charts, so each chart will contain 50 divided on 10, 5 equals 5 units. So the final reconstruction or the final construction will be each chart contain 5 units. So it will be easy to calculate using injection. Okay. So for example, if a certain muscle will be injected 10 units of loss, so I will put 2 shots. Okay, 50 units, I will put a full series. You got it? Easy? The next step is the localization of the individual muscles. Actually, we need a single workshop to study the surface anatomy and the actual anatomy of all the muscles. But this is an example of the other usually affected muscles, like the flexor cardialis, which are the wrist flexors. Also, the flexor digitorum superficialis and profundus, which are responsible for the flexion of the fingers. Also, the abductor pollicis. These are the most common affected muscles in the hand deformities post-stroke. This is an example. About the number of injection sites. If I decided to inject a certain muscle 50 units of dose, shall I inject these units immediately in single injection sites, or should I distribute them in many sites? This will depend on the number and the location of the affected muscles. Number 2, location, how the superficial will be, and the surface area of this muscle. Number 2, the severity of spasticity. The more the severity, the more need to distribute the toxin to many sites. The presence of local muscle weakness. Local muscle weakness, I mean part of the muscle is weaker than the other. The most prominent example for this is the flexor digitorum superficialis, which flexes the fingers. Actually, we can consider it 5 muscles stuck to each other. One for the index, one for this thumb and this thumb and this thumb. If I noticed specific focal weakness in the index finger, so I should be away from while injection from the part of the muscle that flexes this thumb, because I will increase the weakness, and so the patient will lose function. And my aim is to help them to gain function. Okay. Finally, patient response to previous treatment. I mean, I must review myself. In the first injection, I injected the muscles on a single side and the improvement was satisfactory. I should distribute my dose in multiple sites in this. Okay. The recommended dose for the tox, actually we have a chart for doses and we must study the carbon. There's 2 ways to determine the dose. One of them is calculation the dose related to the kilogram of the body weight. Actually, in pediatrics, it's 1 to 2 units per kg of the body weight. Okay, and for the adults, it's 2 to 3 units per kg. Okay, but actually, it will not be accurate or so accurate to use this rule. So we have a chart for individual muscle doses, and we must study it hard. Each muscle has a commonly used dose. Okay, range of dose. The injection technique, we can inject EMG guided or ultrasound guided. EMG guided, we have a portable injector should use or have a portable EMG apparatus. I will show you one of the portable EMG devices that we use in our practice. This is a portable EMG apparatus. Actually, we use it to identify the individuals. So, back again, the EMG guidance is to detect that you are in the proper muscle you selected. Number 2, ultrasound guided. The ultrasound nowadays is a new era. because it helps you for the deep muscles that can't be accurately reached by the EMG, the proton EMG, and actually it helps you to identify specific sites inside the muscle to be injected that will give you more benefit. Okay? Be sure before injection that the box was stored in the refrigerator and reach it your hands cold. Actually, you must ensure that you order all the materials you will use before you pick up the box from the refrigerator. And you must be accurate in your reconstruction process so as not to harm and destroy the toxin. Contraindication for box actually are limited. Restricted only to patients known to have hypersensitivity from previous injections or presence of infection, local infection as a side effect. Storage. Before reconstruction, storage must be in a refrigerator at a temperature 2 to 8 degrees centigrade or in the freezer below minus 5 degrees centigrade. The expiry date is 3 years. After reconstruction, my advice, try to use the box immediately. And if you should reserve it for some time, actually the maximum permitted time is 24 hours, and it should be preserved in the refrigerator at the same temperature, which is 2 to 8 degrees centigrade. But finally, don't exceed 24 hours and then discard it after reconstruction. Okay? What is the follow-up strategy for the patient after injection, and when we will re-inject him again if needed? After injection by 2 weeks, there will be the maximum the start of improvement of the muscle. And at 4 to 6 weeks, this will be the time for the maximum benefit that we gain and we gain from this injection. And then he will be reviewed again after 3 months. If need further injection, you are permitted to inject him after 3 months from the previous one. And please try not to inject anybody again before the passage of 3 months to avoid development of autoantibodies against this toxin, so as the toxin will lose its benefit and it will not be very negative. We can follow up the patient also by the same strategy as we assessed the spasticity before, the same hierarchy, and by using also the Ashworth scale and the stability assessment scale. Okay, this is the stability assessment scale. We assess the patient for 4 points: hygiene, dressing, limb position, and pain. And these data is collected, and we give the patient score. 0 is no disability, 1 is the mild disability, 2 is the moderate, and 3 is the severe. The latest FDA-approved indication for use of toxin. This is away from spasticity. This is just for announcement. It's the chronic migraine. Don't forget that I told you that the tox has a sensory motor effect, not a motor effect only, because it blocks the release of the neurotransmitters involved in the genesis of pain. We have 31 international fixed sites for injection in the chronic migraine, according to what we call the print fixed study injection mobile. PRINT means it is the abbreviation for what we call the PRINT study, which is the study that was done to take the approval for the toxin in this field, which is the chronic migraine. Now we have 3 cases, real cases, and we will inject them with demonstration. But I want to tell you something. This is just, we can call it awareness work. I don't think that anybody of you faced the career of reason for before. Anybody up to that feels that is interested, you can contact me and start to arrange a series of lectures and workshops so as to become an agent. Actually, I can explain this. review the indications for the FDA approved indications, which is the blepharospasm and the epiphyseal spasm, cervical corticolus, and the focal spasticity, and the urinary disturbances. It's related to the neurologists. We won't mention it as a neurologist. And finally, the chronic cardiac. Today, we have three cases. One case of epiphyseal spasm, and one case of corticolus, and one case of upper limb spasticity. So that will cover our indication that you may face in the This gentleman is called Ahmed. His name is Ahmed. He faced skin stroke since 3 years. Then he developed post-stroke spasticity. Although he gave rehabilitation program, that was not very good, and he was not advised to interfere with the botulinum toxin use at the proper time, because there is a continuum, which is the botulinum will not only help the patient to get rid of his spasticity, also it will help and cancels the rehabilitation program to become easier. This is because two items. Number one, the pain. Any patient has spasticity suffers pain in this spastic muscles. So during the rehabilitation, he will not be overwhelmed. Okay. The second step is that the spasticity will reach a high level according to the scale, which is number 4, degree number 4, which is the leg becomes lesion. So the physiotherapist is able to overcome all this degree of spasticity. So at this time we can inject the pulse not only to get rid of spasticity and reach functional goals with the patient, but also to facilitate the rehabilitation